Now, with that understanding of what it looks like, let's focus on some of the common signs and symptoms. These are quite often related to manifestation of anemia, but it will also depend on the rate of development of anemia. Some common symptoms, which are common to all anemias, which are pallor, fatigue, weakness, dizziness, irritability, but they're not very specific to iron deficiency alone. There may also be reduced exercise capacity and exertional intolerance. And then for iron deficiency specifically, there may be things such as pica or pagophagia, which are very classical textual descriptions. There's craving for peculiar foods, non-food substances such as ice, dirt, and chalk. These are seen in substantial iron deficiency. There also may be a multitude of different findings together, or a cluster of them, such as dysphagia, esophageal web, glossitis, as seen in Plummer-Vinson. However, overall, this is very rarely seen together. The other features include glossitis, which is described as a smooth tongue, restless legs, quite common, angiostomatitis, which is cracking of corners of the mouth, and colonychia, which are thin, brittle, spoon-spade fingernails, which are also quite seen commonly in severe iron deficiency. So how do we really test for these? There are some general tests, which are obviously non-specific and are for a lot of anemias in general, but then there are specific tests for iron deficiency. So as you walk down the slide, you look at the peripheral blood smear, look at hypochromasia, red cell indices, which are not very sensitive markers of iron deficiency. But then you look at serum ferritin, and then serum iron to transfer ratio, which is iron saturation, which is key, as we'll talk about in a few seconds. And then the gold standard for iron deficiency would be a bone marrow iron stain on a Prussian blue. However, it's not easily done and is not commonly performed clinically. Now, there are other experimental or underlying physiological markers, such as serum hepcidin, but because of lack of standardized assays or availability of the standard assays, that's not easily possible. Also is an acute phase reaction. And then more and more studies have shown that soluble transferrin receptor is a very sensitive marker for iron deficiency in heart failure. However, again, because of lack of standardized assays of being available, this is not available in clinical practice for now. Looking further into the lab findings, what do you see in the white cell on CBC? You see increased red cell distribution width. You see reduced MCV. You see on the smear microcytosis, hypochromasia, and that's basically widening of the central pallor. And important to remember, compared to other anemias, reticulocyte count may not be increased. Now, coming back to what is very unique about iron deficiency in heart failure diagnosis, these are some of the findings you may see. This is reduced serum iron and ferritin. You also see reduction in iron saturation, and based on recent trial definitions, this is what was used, and now it's been adopted by the recent guidelines, both ACCH and Heart Failure Society guidelines, as well as the ESC guidelines, where it's defined as a transferrin saturation less than 20%, reduced ferritin, and increased iron binding capacity. Once iron deficiency in heart failure has been diagnosed, you really need to calculate the total iron deficiency using the Gonzoni's equation, which is going to help you guide treatment beyond the clinical trial definitions. Again, honing into the definition of iron deficiency in heart failure, remember, if it's a ferritin level less than 100, it meets the diagnosis straight up. Now, if you have a ferritin of 100 to 300 and a transferrin saturation of less than 20%, that it again meets the definition of iron deficiency in heart failure. Let's look at some of the changes which happened as this condition progresses. As we said, it depends on the state of anemia setting in. As the condition progresses from iron depletion to deficiency to iron deficiency anemia, the ferritin levels continue to get depleted or reduced. Iron saturation goes down. and it's later in the stage, hemoglobin and MCV have changes as we discussed before. These are again a way of taking a look at different stages and different findings which may be prevalent in different stages. Again, highlighting that early stages, some of those classical anemia definitions may be missed. As you go from early stage or pre-latent to anemia, you can see a reduction in bone marrow iron, which becomes absent over time, which is again the most gold standard. Serum ferritin is reduced. MCV may be normal in the early stages of iron deficiency until anemia sets in, and then symptoms are present all along, but more accentuated as anemia sets in. How do you differentiate between iron deficiency anemia versus anemia of chronic disease, which other form of anemia? You can see in iron deficiency anemia, there's a reduction in serum ferritin, whereas in inflammatory states, as anemia of chronic disease, there's increase in ferritin. Both have similar reductions in serum iron. However, one of the differentiating things is increase in soluble feed transferrin receptors in iron deficiency anemia. And there is no difference in bone marrow iron in anemia of chronic disease. Now, we talked about impact on prognosis, and this is important. When we look at different forms of iron deficiency and anemia, both anemic and non-anemic iron deficiency had a twofold greater risk for death than those with non-anemic iron deficiency, and a fourfold greater risk for death than those who are iron replete, with or without anemia, as seen on this particular slide. Now, you've diagnosed iron deficiency, you've decided to treat iron deficiency. How do you follow response therapy? And this is something where there's still some gray area. There are different recommendations, and we'll listen to that in Dr. Butler's talk as well. But before that, first thing is to recognize what is a normal physiological response to repleting iron stores. It takes 7 to 10 days for peak reticulocyte count to change. The hemoglobin hematocrit can take up to 3 weeks, and it may take up to 2 months to normalize. And the iron stores take almost 4 to 5 months to get repleted. So it's important to not test early and base decision based on that, but based on your total iron deficiency itself, and based on the standard clinical trial definition which you may be applying to your practice. While there are no gold standard criteria which exist, you can look at ferritin and transferrin saturation at 3 months, as well as moving forward if there's a change in clinical status based on symptoms, or if there's anemia setting in. Otherwise, 1 to 2 times per year is standardized practice. This is a statement from HFSA, which was published recently, looking at how to screen and diagnose for iron deficiency in the heart failure population, especially for patients with symptomatic heart failure with the LVEF less than or equal to 45% and hemoglobin less than 15. You look for severe life-threatening anemia. Obviously, if they have life-threatening anemia, they need to be transfused as needed. If not, then you obtain iron studies, which include, again, serum ferritin and transferrin saturation. If it's less than 100, or if it's between 100 to 299 or 300, then you look at a transferrin saturation of less than 20%. If they don't have iron deficiency at this point, you continue your annual surveillance. If they do, calculate your total iron deficient, whether they are inpatient or outpatient. You replete the iron based on that deficit, and then repeat studies over 3 to 6 months. Both ACC, AHA guidelines, and ESC guidelines have given recommendations for iron deficiency now. And this is from the ESC guidelines, which recommend that all patients with heart failure be periodically screened for anemia and iron deficiency with a full blood count, serum ferritin, and transferrin saturation. And it was given a class 1C recommendation. These are from the AHA, ACC heart failure guidelines as well, which again give a class 1 recommendations to look for iron profile and iron studies, again focusing on serum iron, serum ferritin, and transferrin saturation.